Thank you so much for the Greater Horn Symposium people for inviting me here today. I'm Katie Dusenbery, and I'm from the University of Minnesota. And today I'm going to talk to you about retinoblastoma. And the reason I'm talking about retinoblastoma is an offhand comment Dr. Diefenthal made about 6 months ago to me on a conference call was, gee, we're seeing 2 cases of retinoblastoma a week. And you can't be, you know, it's not possible. I haven't seen a case in 10 years. And he said, oh yes, we are. So I investigated and I believe him. And it's very interesting. And I'm hoping this piques somebody, one of the medical students here, interest in studying why there's so much retinoblastoma in Africa. So what is retinoblastoma? It's a malignant tumor of the retina that affects young children. And untreated, it's 100% fatal. And it occurs, it's a really good model for cancer development. Retinoblastoma occurs as a gene, and that suppressor protein is located on chromosome 13. It's involved in the pathway of activation of cell division, and inactivating that gene and stopping the suppression leads to a variety of tumors, not just retinoblastoma, and it's very much studied as for tumorigenesis for a lot of different kinds of cancers. So what is the epidemiology of retinoblastoma? There's 2 types. One is the type where every cell in your body has inherited a faulty copy of the retinoblastoma gene, so the suppression is turned off and you are a tumor-making factory. That is the familial side, and that's in the United States, about 40% of cases are familial. These kids get their retinoblastoma at young ages, usually under 1, and there's usually bilateral tumors, both eyes, because it's every cell in the body that has had the first hit. It just takes the second hit for the tumor to develop. It's inherited in an autosomal dominant pattern, so theoretically 50% of their offspring are going to get retinoblastoma. It's actually not completely penetrating, so it's about 45%. And as I said already, they're tumor factories. They're at risk for the rest of their lives of other tumors as well. The sporadic, or the non-hereditary type, it's about 60% of the cases in the United States. It's usually unilateral, and they're usually a little older. And it's a somatic mutation, so it's only one mutation in a cell in the retina, and then a second hit happens and they get a single tumor usually. And their children don't inherit this malignancy, this tendency for their kids to have the malignancy. This is what it looks like, and for any medical student, this is going to be on your boards. There's rosettes that are characteristic of retinoblastoma. They're the Flexner-Wintersteiner rosettes. There's about 4 other kinds of rosettes you need to know, but this one's the one that goes with retinoblastoma. We don't usually do a biopsy, so it's really more academic than anything. So what about the worldwide incidence of retinoblastoma? There's a huge variation, I found out. In Bulgaria, it's only 3 per million patients, per million kids. And in Mali, highest reported so far, 42 per million. And it varies between countries and continents. In Asia, 6 to 19, Africa 10 to 42, South America 7 million in Uruguay to 17 in Colombia. Why for this great incidence? It may just be genetic, just like why seems to be no brain tumors. But in Africa, in general, there are 34.2 per 1,000 cases in patients. And what's really astounding is the mortality rate is at least 70% if you take all countries together. Compare that to the United States, where the mortality now is about 3%. So why? Maybe it's genetics, but the other possibility is that retinoblastoma has been associated with human papillomavirus. They've found evidence of papilloma HPV in enucleated eyes. And as you all have heard, there are certain HPV subtypes that are considered to be oncogenic. I've listed the ones that are considered oncogenic there. Some are more oncogenic than others. And interestingly, some subtypes of HPV code for a protein called E6, and that E6 protein inactivates the retinoblastoma gene. So it makes sense that a high exposure in an immunocompromised person might lead to enough E6 protein being produced that it inactivates the retinoblastoma gene and a retinoblastoma develops. HPV has been found pretty much everywhere in the body, and I wonder, how do these kids get it if this is really the causative agent? It's in amniotic fluid, it's in the placenta, they could be exposed during childbirth. It could be a variety of ways. I don't think anybody's worked out those details yet. In India, they've done some studies on this, and this is a paper published about a year and a half ago on the maternal transmission of HPV in retinoblastoma. And they took, I think, 21 women, and they tested them. They didn't have HPV testing in all of them, but they tested them for HPV cervix swabs. And then they had the enucleated eyes, and not all of them could be tested, but some of them could. And in 40%, 11 of the 21 eyes, there was evidence of HPV. And in the mothers that had HPV testing, 30% of them had a concordant HPV subtype. So it's kind of intriguing. It isn't conclusive, but we may be onto something as to why this is happening. So what is the clinical presentation? Leukorrhea is a white pupillary reflex. It's usually inconsistent at first. Parent might notice it, but then as the tumor gets bigger, it's more obvious and more consistent. You can also see strabismus, a red painful eye with glaucoma in more advanced cases, nystagmus, and as it invades the orbit, a swollen eye. But leukorrhea is the main hallmark. And actually, there are papers out, talking about screening and low-cost screening. One of the, if it really is that much retinoblastoma here, another really good medical student project would be to organize cell phone pictures of your kids at certain, times a day and in light, and you could have a protocol, and you could pick them up earlier, just with cell phones. Everybody has cell phones, everybody has a camera on it. You don't need doctors, you could train people how to do that. It would be a great public health project. There are a few other causes of that white reflex, but most of them can be excluded with a careful history. So it's really almost a clinical diagnosis. These are the other diseases that sometimes can have the white pupil reflex, but most of them can be excluded. An ultrasound, which is readily available here, is really the tool for diagnosing and staging. This is just normal ultrasound anatomy here. Anyway, you can, this does work for pointing, huh? Lens here in the front, this is an eye. Here's the lens, retina back here, and this is the vitreous with the optic nerve. It's a normal eye. Here's the retinoblastoma eye, and I'm seeing a little bit of a glare, but as Dr. Diefenthal really clearly showed you yesterday with lots of slides, the hallmark of retinoblastoma is calcifications. If you see calcifications in your ultrasound, you're pretty clearly looking at a retinoblastoma. And here, in this one, the lens is in the front, but this is the retinoblastoma with the calcifications. Here you can see a detached retina. That's part of the staging system. Calcifications, tumor, probably not very well seen. So ultrasound demonstrated evidence of retinoblastoma in 100% of eyes. It's very sensitive. And calcification in 90% in one series. So what is the workup? You don't need to biopsy it. You need a good ophthalmologist or a person skilled in an eye exam for acuity, extraocular movements, a pupillary response, a slit lamp exam, and indirect ophthalmoscopy. And then there's an ultrasound. And at the ultrasound, the radiologist should give the size, location, whether there's vitreous seeding, where it is in relation to the optic nerve, whether it looks like it's endophytic, exophytic. Sometimes they can see it growing into the optic nerve. We usually in the United States get a CT just because we can. We have lots of CTs. We think that's just like drinking Kool-Aid. But you can see the calcifications even better with a CAT scan. And because there is a condition called trilateral retinoblastoma, and that would be both eyes and the pineal, we usually get an MRI scan. Also with an MRI scan, you can see invasion out of the globe a little bit better and into the optic nerves. There's, to make it harder for medical students, there's now a new international staging. When I was a resident, it was the Reese-Ellsworth. And anyway, there's a to E international staging system, and it's very similar to the Reese-Ellsworth, and it goes from A to E, A being a small tumor far from the fovea. B is a little bit bigger, but no seeding. C, when there's some no retinal detachment, but maybe a little fine seeding. D, even bigger with snowballs in the orbit. And E is touching the lens, completely encompassing the globe, or the orbit, and outside of it. So what are the treatment goals? Well, first of all, it's 100% fatal without treatment. So first of all, we want to save a life. And then we want to preserve useful vision. And useful vision is what you have to decide. And then lastly, minimize complications or side effects of treatment. So the current treatment options are enucleation, if it's confined to the globe, or exenteration, if it's coming out of the globe. And then other treatments are, there's local therapies, there's plaque radiation treatments, there's laser photocoagulation, cryotherapy, freezing the little nodules, and thermotherapy. When I was a resident, I was trained well in the external beam options for retinoblastoma. And protons today could be used for retinoblastoma, but we try very, very, very hard in the United States not to give radiation for patients with retinoblastoma, and chemotherapy really has taken front and center stage. So groups C, D, and E usually have very little useful vision, and those patients, usually the best treatment is an enucleation or an exenteration. If there's bilateral disease, you pick the eye that has no vision and remove it, or you might try some chemotherapy to shrink them down and then make a decision as to which eye you might need to take or not take either of them. But C, D, and E are the high-risk patients. What are the indications for enucleation? Well, if it's blind or painful, if there's vitreous seeding, large tumors that take up more than half of the globe with no visual potential, if it extends into the optic nerve, or if you've tried some previous sparing techniques and it's failed, it's time for an enucleation. Anterior chamber invasion is also an indication. And cosmesis, this is the hardest part, talking to parents about it. Cosmesis can be excellent with an enucleation. You put a prosthesis in, patients look very normal, they live very normal lives. And I think that would be a real important aspect of any type of screening and treatment program, is to get acceptance for an enucleation, because I'm sure that's a hard sell. For people in the United States it is, and I'm sure it would be here too. And the other thing that occurred to me during this conference, I don't know if you all are excited as I am about 3D printers, but 3D printers, you can print up a prosthesis that could work really well, and it could be cheap, and it could be cosmetically lovely. I think it's a really good idea for a company. Anybody's interested. What are the, and before I forget, once you've done an enucleation, you really need to look at the pathology. If there's invasion outside, like into the optic nerve, depending on how much optic nerve invasion there is, they're at very high risk for CNS dissemination, and adjuvant treatment is usually given. I think today we would give chemotherapy. When I was a resident, we gave cranial spinal radiation, but they're at very high risk for a relapse even after the enucleation. Who should get an exoneration? Well, if it removes the globe, the muscles, the lids, the nerves, the orbital fat. The cosmetic result is not nearly as good. So you'd like to avoid this if you could. It's indicated for tumors that breach the globe or for recurrence in the socket. And you would follow that up with postoperative radiation therapy because it's not an area that you can get a good margin on, and probably add chemotherapy as well. So today, in the United States, most kids with retinoblastoma get chemotherapy. And the goal is because we're trying to avoid radiation. The chemotherapy alone is great. They got a good response. It's a fast-growing tumor. They respond beautifully. And often the tumors become quiescent, and that's all you have to do. But usually it's followed up with some focal therapy, a little cryo to a tumor that looks like it might still be growing, or a little laser therapy. And they get exams under anesthesia at intervals of 3 or so months, and eventually the tumors quit misbehaving and the patient is cured. The drugs used for retinoblastoma are carbo, etoposide, and vincristine, easily delivered. I really wanted to meet Dr. Scanlon today. This is the first-year experience of chemotherapy at Ocean Road. They treated 37 patients in 2008. They all had advanced disease. A third of them that was ocular. 57% had gotten out of the globe and was in the orbit, and 4 patients had metastatic disease. The chemotherapy, as you'd expect, was very effective. One of the problems was completing the therapy. Those with ocular disease, 67% completed the chemo, and all of them had a CR. Of those in the orbit, only 50% completed the chemotherapy, and 50% of them had a CR. So it's very encouraging first look at treating retinoblastoma here in Tanzania, and a lot more work to be done. This is why we don't want to use external beam therapy if we can help it. The radiation results would be just as good as the chemotherapy, but there are late effects. This is the D-shaped field that we often use, trying to spare the lens. There's controversy over what's the best technique, but treating the orbit, the globe. And this is a patient years later. There's hypoplasia of the facial bones. And if you meet somebody that's had that radiation years ago, you can tell. It's cosmetically not very good, but they often will have very good vision. They caught the tumor at an early enough stage that they didn't need an enucleation, and the radiation. We used to give 300 a day, 2 or 3 times a week, because we were afraid to anesthetize kids 5 days a week, why. And those patients have a little worse cosmesis. In more recent years, when we do radiate, we radiate daily. We radiate 180 a day, and we go to about 4,500. And the retinal tolerance is on the order of 5,000. So most of these people that need radiation therapy do have good vision. They may not have 20/20 vision, but they have very useful vision. And so radiation is a good treatment, but in the last 10 years, I haven't treated a single retinoblastoma patient, and where I used to be treating one or two a year. People have used intraarterial chemotherapy in an effort to try to minimize the systemic side effects. And that's very effective, but that's very high tech. You need an interventional radiologist to catheterize the ophthalmic artery, instill the chemotherapy. Very effective, probably safe, but probably not ready for prime time in Africa yet. So in summary, retinoblastoma is not uncommon, and left untreated, it leads to blindness and death. It may be related to HPV exposure. I'm still on the fence, but it might be. Early diagnosis is the key. A lot of good, easy, low-hanging fruit for screening. Radiation does arrest the tumor growth, but leads to potential long-term side effects in small children, and we'd like to try to avoid that. Chemotherapy combined with some local therapies can preserve vision and arrest the disease. I'm hoping that together we can make this kind of presentation a thing of the past. And I'm very privileged and honored to be part of this great group. And I'm hoping that next year, when we have our next symposium, which I hope there is one, there'll be progress made in this disease and some of the other ones that we've heard about today. Thank you very much.